Chapter 24 is on anesthetic drugs. So to begin with, we're going to talk about anesthesia. So ana meaning without, thesia meaning aesthesia is feeling. So anesthesia is the absence of feeling or sensation or pain. And this can be obtained through several different means. We can apply an anesthetic topically to the skin, or for example, if you've got a toothache, you use Orajel. It can be injected into the skin or deeper tissue through a subcutaneous local injection. That's called infiltration, and that's kind of the same thing as if you're going to the dentist and you're getting numbed to have a tooth filled. Also, we can use anesthesia in one part of the body to block a regional nerve. So we can have, they call it a spinal, a nerve block if there's extreme pain in one area. Also, in the trunk or lower extremities through epidural or spinal anesthesia. And we can cause anesthesia throughout the whole body, and that's called general anesthesia, and that produces unconsciousness. Now, there is an exception to that. Most of your general anesthetics are either going to be injectable or inhaled. So topical anesthesia, we use it for the skin and the eyes, and it comes in many different forms. It could be a cream, a gel, an ointment, or a spray. If you've ever had a sunburn, you maybe have used Solarcaine. It comes in a lotion form, but it also comes in a spray form. There's lidocaine ointments that contain aloe vera gel with lidocaine for sunburns. So many different routes or many different dose forms. For local, regional, spinal, or epidural, these are all considered to be more of a local anesthetic. These types of anesthetics are given subcutaneous into the skin to numb locally. So if you needed to have stitches, so they can do some infiltration into that small area, or if it's for a minor procedure or a dental procedure. For regional anesthesia, the anesthetic drug is subcutaneous near a nerve plexus and its branches. So that's used for surgery on extremities. It's also known as a nerve block. Now, this picture from your book shows a subcutaneous injection of the anesthetic drug into that subcutaneous tissue, causing infiltration. So they fill in that space. Spinal anesthesia, the anesthetic drug is given by injection into the subarachnoid space between the vertebrae of the lumbar region of the back, and an epidural is given it in the epidural space. And epidurals are quite commonly used in labor and delivery. Now, the medications that are local anesthetics used for these routes of administration, they do have a drug stem, and that drug stem is cane. So you see here, cane. So bupivacaine, which is Marcaine or Sensicaine, chlorprocaine, lidocaine, mepivacaine, procaine, ropivacaine, tetracaine. So they all end in cane, and that helps you identify a local anesthetic. Here's a vial for lidocaine. Most of your local anesthetics are going to be have a dose strength in a percentage amount. So you always want to be careful that you're checking the dosing when you're pulling a vial to make sure that you have a proper concentration of that. None of these local anesthetics that end in cane should be administered in an IV. There is an exception, that's lidocaine. That's the only one, and it's used as an antiarrhythmic drug. All of the rest of your canes are local anesthetics. Now, they do work differently in their duration of action. We have short-acting and long-acting, and how they metabolize is slightly different. A short-acting local anesthetic is known as an ester, and those actually metabolize in the tissue where they're injected. A long-acting anesthetic is called an amide, and those actually absorb and then are metabolized in the liver. Now, it's not on your list, but cocaine is a drug that ends in cane. It is a local anesthetic, and like I mentioned in class, we do use it for some eye and ear procedures in TAC solution, which is a combination of tetracaine, adrenaline, which is epinephrine, and cocaine. But we don't use it as much as we once did. Now, you want to be careful because your canes sound alike, look like. Chloroprocaine and procaine are examples of those salad drugs. We also have combination anesthetics. They help provide local or regional anesthesia. Duocaine, which is bupivacaine and lidocaine, mixing together a long-acting and a short-acting. Another thing as I'm thinking and looking through this chapter, I'm not recalling seeing it on the slide, but often with a local anesthetic, they'll add epinephrine, which is the brand name adrenaline. Your local anesthetics have a vasodilating property, with the exception of cocaine. So if you've ever had an injection of a local anesthetic to get a filling in the dentist's office, you may have noticed that warmth kind of feeling as that anesthetic is spreading. The vessels are dilating, which brings blood in there and increases the temperature, or it gives you that warm feeling. Because they could wear off because of that vasodilation, bringing blood into the area can help increase the rate of the metabolism. Using epinephrine, which is a vasoconstrictor, can actually double the duration of action of a local anesthetic. So we don't have to give more. Some patients do have a sensitivity, especially if excessive amounts are being used. Now, for your local anesthetics, some of the trade names end in MFP, or I'm sorry, MPF, which stands for methylparaben free, which is a preservative that has antibiotic and antifungal effects. Some patients may be sensitive to that, so we need to be careful and not use those medications in somebody who's allergic to that. The local anesthetics, it is in the slides. Okay, so this is just what I was talking about just a moment ago on the previous slide, adding epinephrine into the injection to help increase the duration of action. The other benefit, especially with giving stitches or doing a dental procedure, is that vasoconstriction helps reduce the blood bleeding component. Now, when we use epinephrine, it is contraindicated in certain areas of the body, places that don't have a lot of blood flow. So the tip of the nose, fingers, toes, ears. We don't want to cause necrosis by constricting those blood vessels. Now, moving into general anesthesia. General anesthesia, the difference between local and general, you're going to have, we can think of that as consciousness. So with a local anesthetic, the patient's going to be awake. With a general anesthetic, the patient's going to be asleep, basically, and unresponsive to painful stimuli. So when we're giving general anesthesia, there are some other factors that happen in the body. With many of the inhaled anesthetics and many of the injectable general anesthetics, it can cause increased histamine release, which can cause increased production of phlegm and mucus. So we use medications. Now, also with general anesthesia, somebody's having surgery, probably. So there may be pain that's associated with it. When patients are undergoing a procedure that requires general anesthesia, sometimes they're anxious. So we give a number of different drugs preoperatively to help with a number of conditions or concerns with the procedure. So we want to give sedation, dry up secretions, and help with pain. So to help dry secretions, we would use an antihistamine drug. So antihistamines have anticholinergic effects. So they dry things up. Also, they make you drowsy. So they help provide sedation. They dry up secretions. That helps facilitate intubation. And drugs that we could use include diphenhydramine, which is Benadryl, which is not on this list, hydroxyzine, which is Vistarel, or promethazine, which is Phenergan. The other benefit is these drugs also help reduce nausea. So some of these general anesthetics can actually cause the chemo trigger zone to be activated and make a patient feel nauseous. So there's a picture of the hydroxyzine vial. Now it is important, hydroxyzine is a salad drug, to hydralazine, which has to do with lowering blood pressure. So we don't want to mix those two up. So your anticholinergic drugs, they block acetylcholine. They decrease oral secretions to facilitate the endotracheal intubation. And that includes atropine and scopolamine. Now, these aren't going to have the sedative properties an antihistamine would have, but they still have the same drying components. We might use anti-anxiety drugs to help relax the patient. Also, they can be used to help sedate. Remember, anti-anxiety drugs are sedative hypnotics. We use these drugs prior to endoscopy, cardiac catheterization, and for minor surgical and dental procedures, as well as induction to kind of put the patient to sleep before we try to place their endotracheal tube and give them other general anesthesias, inhaled or injectable. The patient is usually able to respond to commands to help facilitate the procedure, but these drugs cause amnesia, so they don't remember. Makes them kind of drowsy, but kind of puts them out of it, so they're less anxious, but they don't necessarily remember. Primarily, these drugs are benzodiazepines, which means that they are C4s. It includes chlordiazepoxide, which is Librium, diazepam, which I have no idea why it says Vistarel. Diazepam is Valium. Lorazepam, which is Ativan, and midazolam, which is Versed. So let's just see about fixing something here. We're going to do this, and we're going to fix that, and we're going to make that Valium. And make that correct. All right. Also preoperatively, we may use narcotics. That has a twofold purpose: to help relieve pain. So when the patient's coming out of their anesthesia, hopefully the narcotic's still on board to help relieve the pain, and also to help provide sedation. Your narcotics are Schedule II drugs: levofanol, which is levodorphamin, dromorin, meperidine, which is Demerol, morphine, Duramorph, and oxymorphone, Numorphin, or Opana. Other Schedule IV narcotic drugs that are Schedule IV: butorphanol, which is Stadol, or pentazocin, which is Talwin. And we can also use sedative hypnotic drugs to help put the patient to sleep. Drugs such as chloral hydrate, which is Somnote, which is a Schedule IV, droperidol, which is Anapsine, or dexmedetomidine, which is Precedex. Also, to help with sedation or induction for intubation, we use barbiturates, pentobarbital, and secobarbital can be used. Also methotrexate, which is Brevital, is a barbiturate drug that can be used as a general anesthetic. We can also use antipsychotic drugs to help decrease anxiety, which is chlorpromazine, which is compazine, which actually is an anticholinergic, antihistamine type drug. It's similar to Phenergan. It's in the phenothiazine family. So the general anesthetics themselves, they induce loss of consciousness. The whole body is affected, and that's what makes it different from the local anesthetics. Local anesthetics are just going to be one area. Now there is an exception with general anesthesia, and it's an inhaled, and that's nitrous oxide, and we'll talk about that in just a minute. So with general anesthesia in the operating room, first we have induction. So first we're going to give a drug that will induce the general anesthesia. It's usually given intravenously. It could be a narcotic. It could be a drug like propofol. Then we have maintenance. So we need to maintain. There's actually 4 stages of anesthesia. The first stage is analgesia, where the pain goes away. The second stage is actually an excitatory stage. So we need to get the patient through that to get them to the third stage, which is surgical anesthesia. And that's where we're going to perform the major surgeries. Everything's very relaxed, and the patient has no feeling. Now the fourth stage can result in death, so we don't want to take a patient to the 4th level. The maintenance is the 3rd level. It can be given by an infusion, but most often it's going to be given by inhalation. If a patient is intubated, they have a tube in their throat, the inhalation can be given, and it has to be administered by an anesthesiologist, and they have to make sure that it's mixed properly with the right amount of oxygen so that the patient doesn't become hypoxic. Now for the intravenous general anesthetics, they generally provide a rapid loss of consciousness. It helps the anesthesiology initiate anesthesia quickly by minimizing anxiety. And it's got different categories. There's ultra short acting barbiturate drugs. There's narcotic drugs, sedative drugs, and anti-anxiety drugs. So some of the drugs are used by themselves that will provide a light sedation for short procedures, or they can be combined with one or more of the other anesthetic drugs to give a more balanced and sustained level. The intravenous drugs for general anesthesia may be in any of the schedule classes, 2, 3s, or 4s, but the short duration of use in surgery eliminates the possibility of addiction. So it's not something a patient's going to take for an extended period of time. So we don't need to worry about that. Now we do use barbiturates for general anesthesia, and we often combine these with other drugs to help maintain the general anesthesia. Now the thing about barbiturates is they can suppress the central nervous system, which can suppress the breathing component in our brain. So that's a high concern. So the anesthesiology has to keep an eye on the patient's respirations, their oxygen saturations, their blood pressure. So it's very, very important. The barbiturate drugs for general anesthesia are given generally in a higher dose than they would be for sedation, just like insomnia or something like that. So the thing about barbiturates is they don't have an analgesic effect. They just produce the unconsciousness. So the drug methotrexate, which is Brevital, is a C4, and that's the anesthetic barbiturate. Narcotics can be used for general anesthesia. usually combined with other drugs to help maintain the anesthesia. They bind with opiate receptors, help block pain, and then in higher doses produce unconsciousness. Again, watched by the anesthesiologist to prevent the depression of the central nervous system to the point of death. We don't want that to occur. We need to keep them in the third stage of anesthesia. So some of the narcotic drugs used for general anesthesia. Now, you've got to be careful because we do have sound-alike, look-alike drugs. So L-fentanyl, sufentanil, fentanyl, they all kind of sound similar. Here we have an ampule of sufentanil as an example. So when I worked in the hospital, I sometimes would work in the OR pharmacy, and they would come down to pick up medications for inducing anesthesia. And they would come, and quite often the mix they would use would be something like fentanyl with Versed kind of thing that would help put the patient to sleep and help with pain. Additional drugs used to obtain general anesthesia. We have ketamine, which is Ketalar. It's a C3 drug. This drug doesn't really put the patient to sleep. It gives us a state that's called conscious sedation. Ketamine is a very short-acting drug. It's only active for about 5 minutes or so. So if somebody's got a dislocated shoulder or a simple fracture that just needs to be set, and we don't want to put them to sleep, and we don't have to take them to surgery, but it's very painful, so we need to kind of knock them out for a minute so that they can get through that short procedure, this would be an appropriate drug. It is a C3. It's highly controlled. It is related to PCP. So sometimes we have what's called an emergence reaction, where the patient can be kind of psychotic when they come out of the state from using this drug. Now, the handling of this drug, it is tightly controlled. Even though it's a 3, it's only used when it's ordered. The pharmacy brings it and hands it directly to the physician, and then after the procedure, it's returned directly to the pharmacy. So the nurse is not usually going to be in the chain of handling this, where they might be with other medications. Also, we can use drugs such as fospropofol, which is Lucedra, which is a C4, or midazolam, which is Versed. That's Versed. Like I said, we often mix Versed with fentanyl for anesthesia. And then the non-scheduled drugs, etomidate, which is amidate, that's very short-acting. Generally, we use that to place the intubation tube. So we can see down the patient's throat to get that tube down properly into the lungs and not into the esophagus. And then the other drug is propofol, which is Diprivan, which nowadays people refer to more like Michael Jackson juice. But prior to the unfortunate incident with this drug and Michael Jackson, we referred to it as milk of amnesia because it's a milky, fat-based substance. Now, the IVs for general anesthesia generally have a high lipid solubility so that they can pass that blood-brain barrier that can help put the patient to sleep. Now, sound-alike, look-alike drugs, as I stated, fentanyl, sufentanil, fentanyl, fospropofol or propofol, so making sure that we've got the correct drug. Also, to induce general anesthesia, we have inhaled anesthetics. These are gases or volatile liquids. That means that it's a liquid that when it's exposed to air, it evaporates very quickly. The first ones that we used were ether and chloroform. We don't use those anymore. The ones we use now, they're often used with other drugs Desflurane is suprane, enflurane is enthrane, isoflurane is forane, and sevoflurane is altane. So you see the drug stem here with that fluorane. Now, I stated before that there is a exception. Whoops, that's not what I wanted to do. I thought I was going to highlight. I'm in the wrong place to highlight. Let's see if I can do this. That's not it. Whoops, I didn't want to change my screen there. Let's see. Is that the right one? No. No, that's not it either. I guess. There we go. All right. Now I'm going to highlight. Okay. So nitrous oxide. What's special about nitrous oxide? Well, some of you maybe heard of nitrous oxide. It's commonly referred to as laughing gas, but it's also what's often used in the dentist's office. So all of these, it's very important that they're mixed with the right mix of oxygen, so the patient's not hypoxic. But the nitrous oxide, its quality is it only takes patients to the first level. So it only helps with analgesia. It doesn't take a patient further unless it's mixed with other drugs. So nitrous oxide's just going to help with the pain, although it can give the patient a euphoric feeling. That's why it's called laughing gas. It makes them feel good. But it's generally not used for more in-depth surgical procedures. It's for more of those minor procedures, maybe with some dermatological procedures or dental procedures. So here's a picture of somebody getting inhaled anesthesia. Now in this picture, the patient's awake. The patient may not remember because maybe they were given Versed on their way in. So we start those narcotics and things, so they're kind of groggy and asleep before they come into the surgical suite. So it helps reduce their anxiety level. Giving the inhaled anesthetic, everybody who has a major procedure is given general anesthesia, but a lot of times the patients don't remember. But if they have a sore throat after, it's generally because of the tube. Now, medications that are adjunctive to surgery that are with the general anesthesia are drugs called neuromuscular blocking drugs, or NMBs. These drugs are meant to paralyze muscles. It causes complete muscle relaxation. The muscles don't respond. These drugs are given IV. They block the nerve transmission. It helps place the endotracheal tube. It's very, very important when a patient is given these drugs, they must be on artificial respiration, because these drugs paralyze all muscles, including the diaphragm. So if they're not on a breathing machine, they're not going to be able to breathe on their own. Especially used with abdominal surgeries because they need to be able to see the full operative field. There's two groups with these. These drugs work on the cholinergic nervous system and disrupt acetylcholine transmission, which is important for muscles to function properly. So we're not going to go into the whole polarizing, depolarizing component of this. Just know that there's two groups. So one group has a drug stem of curium or curarium. So we've got atracurium, cisatracurium, mivacurium, pancuronium, rocuronium, and vecuronium. And then the other group only has one drug, and that's succinylcholine. Now, succinylcholine is non-reversible. There's no agent to counteract it. There are drugs that will counteract the other curiums and curariums and curoniums. Another thing about all of these drugs is that they need to be refrigerated. When taken out of refrigeration, they do